like it's a membrane or a plastic. So when it comes to ELISA, you have buffers and all these, and there might be serum samples that react with matrix. But yeah, without clinic, it's always no no diagnosis without the clinic in this case.
And what about the 1+ and 2+ in the blots?
Also always
confirm
IFT and clinic. I know this is because, and we come always back to the strategy. First IFT, if this is negative, why going on?
Yeah, suppose you have A and a negative, you can expect a SSA to be positive. SSA in a blot would suppose it is 1+. So how do you 1+ may be negative actually by a blot?
No interpretation without the clinic. So this is when it comes to ANA, something else is important when we have to consider the blood results. The DNA, the double-stranded DNA, has a lower sensitivity using a membrane. So DNA as an antigen is a little bit tricky. So you extract this from cells, you purify this, and either it's removed of its histone proteins. I mean, you have an artificial antigen. Then you coat this on plastic, or you have it in a radioimmunoassay, or you have it in criteria or on the membrane. So the behavior is different. So, and when it comes to the immunoblot, the DNA sensitivity for these antibodies is comparable with criteria. So not the highest sensitivity. So this is also something which one has to consider. So immunoblot for all the antigens is very good using immunoblot for all the ANAs, with the exception of DNA. If this is negative, but there is a suspicion of SLE, just go on with an ELISA.
Any questions?
My question was related to dsDNA, NCX, ELISA matter.
Ah, yeah, okay.
First, is immunofluorescence the recommended one? NCX is the better one, or criteria as you recommended should be the one? How should we choose as to which one to do the test with for dsDNA especially? Which one is the best out of these three?
The ELISA, the NCX ELISA. Do you use the NCX ELISA?
We use NCX ELISA, but off late, since we get proficiency testing for CAP samples, there are a lot of discrepancies happening off late with dsDNA. Wherever there is a borderline positivity, after using this NCX, we are underreporting it, which is normally present, or it's either way around. So anywhere the value between 0.7 to 1.2, we are not very sure. And since the back insert doesn't say, the cutoff is 1. There's no borderline range as it is.
Yeah.
So should we have that, or it's not happening properly with us? So is there a reason? What is your viewpoint over that?
This is a 2-in-1 question. So one problem is CAP itself, what I think. So the problem with the quality assurance program is that they do not use clinically characterized sera. They determine the result based on 80% agreement of the results, which means if 80% of users are using the same test, you get the agreement of these, if this is negative or if this is positive. So, but this does not say anything about is this true positive or true negative. So you have to consider the clinic and several tests. And in CAP, it's just this 80% rule, which is not the best way. Another thing is, and this is not just the problem with CAP, this is with many quality assurance programs, they dilute the samples to have enough aliquots for everyone. And this results quite often. We have also in Germany with the quality assurance programs the problem, they dilute the samples and then the antibodies have only a borderline titer. So, and when you have an antibody, it's different to a hormone. So you have absolute values, you have a linear behavior of the concentration. But antibodies, they behave differently. So you have high affinity, low affinity, and if you have a borderline concentration and you repeat the incubation several times, you might be sometimes positive, sometimes negative. And so this is another problem with the quality assurance program samples if they use borderline and then look for an agreement. But yeah, when it comes to the DNA, sensitivity and specificity regarding the tests. So there is a certain range, so to say, between the different tests. So this makes this antigen not easy. I have this on here. What you see here is that regarding the sensitivity, so the FAR assay is supposed to be the gold standard beside the criteria. But when it comes to sensitivity, is there a pointer on? No. You see that FAR assay and in this case the NCX have a similar sensitivity compared to a classical ELISA. And then comes the blot and the IFT, which means criteria. So blot and criteria are similar regarding sensitivity. The criteria is described as a high specific test, but the sensitivity. So this is the problem. And just to explain for everyone what's behind the name NCX, just some words regarding this. I mean, the target antigen is not the pure phenol extracted DNA. This is not what you have in your cells. So in the cell, it's packed to nucleosomes and then formed to chromatin. So we have the histone proteins included. So and the DNA is wrapped around it to nucleosomes. The problem with the nucleosomes is that a conventional nucleosome preparation would give false positive results regarding antibodies in systemic sclerosis. What is important to have a proper nucleosome preparation? This means a proper isolation of the nucleosomes using density gradient centrifugation. And then you get mononucleosomes which are free of H1 and SCL70. I mean, SCL70 is topoisomerase. This loves to stick to the DNA. And if you do not get rid of, you get false positive result. So with this special nucleosome preparation, you can use this as a linker. The thing is that conventional DNA do not work without a linker. So the DNA does not like to bind on the plastic surface without a linker. So what is usually used is a protamine sulfate. But then you risk also to get false positive result if the antibody binds to protamine sulfate. What's behind the name NCX is that instead of protamine sulfate, this highly purified nucleosome preparation is used as a linker plus the DNA. So you have the purified DNA and you have the nucleosomes which also contains the DNA in its conformational shape and so on. So because this nucleosome preparation is also specific for SLE, so you will not get false positive cases as in protamine sulfate. And here we have some data regarding sensitivity and specificity. And you see here, so the criteria has a sensitivity of 27%. It's supposed to be the standard in many laboratories. But if this is negative, you cannot exclude the presence of the antibody. Then you see the classical dsDNA ELISA with 41% sensitivity, nucleosome 46 for SLE, then the radioimmunoassay 51, and the NCX 59. This is in this cohort. Each SLE cohort is different. You have active forms, inactive forms, so the prevalence varies as well. Regarding the specificity, you see they are more or less all comparable. And when we come to the question, which is the best test, most sensitive, it is difficult to say. In this comparison, when you look at these, the classical dsDNA, the nucleosome, the NCX, you see that there are 13 samples positive with the NCX only. So we have, as I mentioned, with this nucleosome package as linker, somehow an authentic presentation of the dsDNA. More important or more interesting is this correlation. We see with the RIA, you get 6 isolated positive. With the criteria, you get 2 isolated positive. With the NCX, 29. So the question is, which is the right test? This is difficult to say. I mean, the most sensitive test, as you have seen, is the NCX. And you have a borderline result, but however, if you would use another test, you might have clear negative, but then probably not borderline. But we have to differentiate between CAP and general diagnostics.
You mean to say NCX will give less positivity because it's not taking into account the protein, protamine, and the lysine activity of other ELISA tests?
No, it's more sensitive than the classical.
Because other contemporary ELISA tests will take care of protamine and lysine as positivity, which is not done by...
This would be false positive, but we also talk about the sensitivity. The protamine sulfate, I mean, I don't know how many cases would you find with false positive. This can occur, but it does not mean that 50% of your results would be false positive.
That would be the reason when we evaluate the entire CAP-PT result, only Euroimmune was the company which uses NCX, gave out of 6, 3 positive and 3 negative, rest all gave negative.
No.
I don't know why the discrepancy is happening in that case.
No, but I'm not sure if you get separation of different methods used in CAP.
All ELISA-based.
All ELISA-based, okay. Okay. And all put together for the result, for the agreement?
ELISA and NCX definitely was there in the result.
Yeah, but is the immunofluorescence taken also into consideration for the result?
Not really, but ELISA
For the 80% agreement, that's what I mean.
No, not for that, only ELISA and NCX, both put together. Only ELISA and NCX, not the immunofluorescence.
I mean, when we go back, you see that 75, no, even more, 85 samples are positive in NCX and as well as in the classical ELISA. I mean, this is not the rule for every sample of CAP or of any else. I mean, this is now this CAP sample, but there might be different reasons. But the problem is that they have this 80% agreement and they don't use clinically characterized samples.